All right, here we are. We're going to talk about assessment of fetal well-being in week number 4, right? Week number 4. All right, plenty of diagnostic procedures that we have available to any pregnant woman. Some high-risk pregnant women experience all of these and frequently, and we'll talk about each one. The first one we're going to talk about is ultrasound. Ultrasound is, I don't know, it's pretty cool, in my opinion. It takes, like, sound waves and creates images. It's the window to the womb, really. Pretty cool. We do this early in pregnancy to date a pregnancy, meaning, what's her due date. We might do it along the way to assess the health of the placenta, the growth of the baby, and all sorts of things like that. Fluid levels, that sort of thing. And then there's Doppler ultrasound, and a Doppler blood flow study is really helpful in pregnancy. We analyze the blood flow to and from the placenta, which is very helpful for babies who we think might be a little small, or for women who have some high risk categories like hypertension, gestational diabetes, things like that we know already affect the blood flow to the placenta. We want to make sure, or that they can affect. We want to make sure that they don't, or that what blood flow difficulties there are not affecting the blood flow to the baby. Holler out if I'm doing anything not in order, because I. All right, hold on. I get it, because you know why? Am I so far?
Yeah, for mine you are.
Oh, I get it, because it's two-sided. Ready. That's good. Not bad. I seem to know what I'm talking about. All right. Now there's a really specialized ultrasound we call the biophysical profile. It's done in the 3rd trimester and very regularly, once a week generally, with some high-risk pregnancies, including gestational diabetes, hypertension, the elderly, or what did I hear recently? Geriatric pregnancy? Yeah. I got a problem with those terms.
Yeah.
Geriatric pregnancy, which means 35 and older, by the way. I know. And some obesity, if it's extreme obesity. They might do this biophysical profile weekly, along with a non-stress test, which we'll talk about. Biophysical profile is a very focused ultrasound that includes a non-stress test, which is the fetal monitor. We'll speak of that momentarily. We look at fetal breathing movements. While they're not actually needing to breathe, in the 3rd trimester they practice. They practice breathing movements. We want to see that. Gross body movements, just like we're checking afterwards, right? We want them to be moving their body in big movements. We're looking at their fetal tone. So what they're like without moving, are they nice and flexed like we want them to be after birth? They should be that way before birth. And we're looking at the amniotic fluid volume. All right? They get a score. I'm not asking you to memorize this. I'm asking you to know what a biophysical profile includes. All right? What it includes, what it doesn't include. It doesn't. Have you noticed I didn't say anything about fetal weight or fetal gender? Cool to know, but that's not what the biophysical profile is about. It's talking about the fetal well-being during a crucial time, okay? Then there's a non-stress test. The non-stress test is we put the woman on a fetal monitor, external fetal monitor. She doesn't need any to be in labor or anything like that. And we have her press a button when her baby moves, when she feels her baby move. Just like you and I when we run up the stairs, or in my case, when I just like stand up from a sitting position. Sorry, that's what it's about these days. Anyways, our heart rate our heart rate goes up, right? When we exert ourselves. Well, that means we're neurologically intact. So we would expect a fetus in the 3rd trimester to have the same reaction, all right? So we put the woman on the monitor. We give her a little button to press when she feels her baby moving. And then we watch on the monitor to see what the heart rate does when the baby moves. And what we'd like to see is that with the fetal movement, the fetal heart rate accelerates at least 15 beats per minute and stays accelerated for at least 15 seconds before returning to a baseline. All right? So 15 by 15. Cool?
Can you say that one more time? It stays.
So, yep, the fetal heart rate accelerates at least 15 beats per minute, stays accelerated for at least 15 seconds, and then returns to baseline.
After he kicks.
Yeah,
Or she.
yeah, movement.
Okay.
All right? If the fetus has moved with those 15 by 15 accelerations, that's what I'm calling it, 2 times within a 20-minute period, we consider that a reactive non-stress test. Make sense? The child reacted to movement, so it's reactive.
So if he does that 2 times in 20 minutes, that's...
Yep. If we don't have that, sometimes we might give mom some juice or crackers or just cold water, something like that, just to see. Maybe she's just a little low, maybe the baby's quiet. We'll keep her on the monitor for a period of time because sometimes babies are just in their sleepy period. I used to get called when I was in the OB office. I would get the techs or the medical assistants, I think they were called, right? Medical assistants in the OB office would actually put the patients on the monitor and then bring the fetal monitor strip to the doctors for their review to say whether it was reactive or non-reactive. So I would get called for the same patient over and over again. And I said, because the baby wasn't moving, and she'd go for an extra ultrasound and all this stuff. And I said, does your baby, when you're not here at this time of day, does your baby move a lot? No. They're usually quiet during it. I'm like, how's about we change the time of your appointment? If every time you're here for an extended period of time because your baby's not moving and we're concerned and we send you for an ultrasound, how about we just change the time of your appointment to a time when your baby's more active? And I never got called for her again. Either that or I pissed her off. I don't know. Sorry. No, but we got to work with the kid too. And the kid needs to move in order for us to find out if they're going to react to the movement in the way we want them to. Does that make sense? Mm-hmm. Okay, cool. So if they don't move, that's one thing. That's kind of a neutral thing. When we want them to move, but if they don't, we got to figure something else out. We'll do our little tricks. We might jostle their belly a little bit. There's a acoustic stimulator, which I do not like. It's like a bzzz. It's not a taser. It doesn't, but it makes a loud noise on the belly. I don't like it. I think that's too harsh of a stimuli for a precious little fetus. But needless to say, some do that to get the baby moving. I prefer to orange juice, crackers, cold water, a little gentle nudge, that sort of thing. If that doesn't work, we bring them back, or we let them go. And if the baby doesn't move in the next hour, then call us back. If not, come back either later that afternoon or tomorrow for the exam, that sort of thing. If the baby does move, but doesn't accelerate their heartbeat, that's considered a non-reactive, non-stress test. If you're looking at the word itself, it makes sense, right? It's not reacting to fetal movement.
Is there parameters, or is it just, the heart rate is a little...
The parameters are 15 by 15.
Okay.
Yep. So if it's 10 beats per minute acceleration, it doesn't. Yep. If it reacts and goes up 15 beats per minute, but it's only up for 5 seconds before it comes back down, it still doesn't meet parameters? That's a good question. Thank you for asking it. So there are some pictures for those who have the PowerPoints. There are some pictures of what reactive looks like and what non-reactive looks like. Basically, it's a squiggly line for reactive with a couple of hills in there, and we'll talk more about fetal monitoring shortly. And then a pretty flat line with no reactivity whatsoever for the baby, despite movement. Now, a contraction stress test is another thing. Non-stress test means we're not stressing the baby out by just having them move, all right? But a contraction stress test means that we're going to stress the kid out a little bit and see what they think of it, all right? Way back in week 1, I talked about when the placenta is delivered, it's an open wound there, right? So we wanted the uterus to contract down to pinch off all the blood vessels so that the patient didn't bleed too much, right? Well, if the uterus is contracting down, which it has to go into labor, placenta's still there, baby's still counting on it. The uterus contracts and pinches off all those blood vessels because the muscle's contracting. That is a stress because in the blood flow decreases, hence oxygen level or oxygen supply decreases for a period of time. A healthy newborn with a good supply otherwise can handle the stress of a 1-minute contraction. Can handle it. They're like, all right, I know it's coming back, I'm fine, I got a reserve in there, okay? A baby who's already struggling with the supply that they're getting cannot handle the stress of a contraction. So what the child is going to do is going to decrease their heartbeat during a contraction or starting at about the peak of the contraction and then going down a little bit. All right, it's called a late deceleration. So a contraction stress test, I don't see them done very often anymore because we have technology like the biophysical profile and stuff like that we do more frequently. Because a contraction stress test means we're actually stimulating contractions in a patient. So we're making her have contractions with Pitocin or otherwise. So we don't want to stress the kid out if we don't have to. But labor is just one big contraction stress test, right? So anyways, it definitely tells us a lot about how the baby's health. To watch how the baby behaves during the stress of a contraction. If there is decelerations with the contractions, we call that a positive contraction stress test, which means not good. I think we should change the wording on that, but that's what it is. If it's a negative contraction stress test, that means the kid did just fine. It was negative for decelerations. All right, so negative is good in this case. Positive is not. Then we have an amniocentesis. An amniocentesis is done at a couple of different times during the pregnancy, depending on what they're looking for. An amniocentesis is ultrasound guidance, so they got an ultrasound on looking for a pocket of fluid in the woman in the uterus, and then they stick a big old needle into the woman's abdomen, into her uterus, and they pull off a sample of amniotic fluid, and they test it. Again, depending on when they're doing the pregnancy will depend on what we're testing for. Early in the pregnancy, we're testing for chromosomal abnormalities. So some of those screening tests we're going to talk about next might come back with a high risk for, say, Down syndrome. So if they really want a definitive diagnosis, they're going to go in and they're going to pull off the amniotic fluid in an amniocentesis and study the chromosomes. Okay? Later in pregnancy, we're looking for lung maturity. We want to know if the baby's lungs are mature. We found that if a baby's lungs are mature, they're letting off some proteins that we can find in the amniotic fluid. Why is this important? Well, this is important if mom has a medical condition that we're walking on eggshells with. Maybe mom's blood pressure is getting so high we really don't want to, and nothing we've done is helping. All right, so mom's health is in a precarious situation. All right, we would prefer her not to be pregnant anymore. All right, but we don't want to stress the kid out. We don't want to deliver the baby early for them not to be able to breathe. So we're going to manage her until the baby gives us the signal that it can breathe on its own. All right? So this is like at the 34, 36, 37 weeks where it can be touch and go. Like some babies can breathe on their own at that age and some can't. So that's why we would do this invasive procedure to find out. What we're looking for is a lecithin sphingomyelin ratio, LS ratio, all right? An LS ratio of 2 to 1, we know the baby can breathe, and we'll proceed with getting that kid born so that we can treat mom more aggressively or end whatever it is that's causing her to be so sick, all right? Gestational diabetes is another one. If her diabetes is out of control, we worry about her health, but more importantly, we worry about the baby's health, all right? Because we know that late in pregnancy, an uncontrolled blood sugar can lead to fetal death. So, but we don't want to put the kid at further risk by having them not be able to breathe on us when they are born. So we do that LS ratio, lecithin sphingomyelin ratio. We want it at least 2 to 1. With gestational diabetes, I think it's like 2.5 to 1. But that's what we're looking for fetal lung maturity, okay? Because it's an invasive procedure, they do have a nurse in there. They have an ultrasound tech usually, but it's the doctor who's usually, and it's done like in a testing center. It's not done like on OB or anything like that. So they're, the needle that's going in is guided by the ultrasound machine so that we're getting it inserted into the pocket of fluid that we're looking for, all right? And the nurse just monitors the patient before, not so much during because they can't really get to it, and after, monitoring mom's vital signs and that sort of thing along the way. They might give mom RhoGAM if she's Rh negative, right? Just because there could be some mixing of blood along the way. And just monitoring afterwards to make sure that the woman and baby have handled the procedure well. All right, it's not without its risks. I mean, we're sticking a big old needle in a woman's belly, uterus, and into her amniotic sac. So think about it: bleeding, rupture of membranes, infection. That makes sense, right? So, just because they're pregnant doesn't mean those aren't risks. One test that has been actually around for a long time, I still find quite incredible. It's called the percutaneous umbilical cord blood sampling. So again, ultrasound guidance, they stick a big old needle in. Instead of getting into an amniotic pocket, they actually continue into the umbilical cord, into the blood vessel, and they pull off fetal blood. Talk about, some people struggle with starting IVs. That's pretty impressive. With ultrasound guidance, getting that needle in and pulling off fetal blood. Wow. What can we do with that? Well, we can do a number of things with that. We're testing it for anemia. We're testing the blood type. All sorts of things, all right? It's obviously not a test we are flippant with. We have serious concerns about the health of the baby to make the risks of that procedure outweigh the benefits, all right? Or the other way around, the benefits outweigh the risks. Because we can have a hematoma, we can have infection, we can have bleeding, we can have, some major things go wrong if it doesn't go well. But if a fetus, we're concerned about severe anemia. All right, maybe mom didn't get ROGAM with a prior pregnancy, and now we're concerned that mom's blood is destroying baby's blood because she has the antibodies, and we're concerned that baby's severely anemic because of the antibodies attacking baby. We'll do this test and pull off blood to find out just how anemic that baby is. All right? This is where I think it gets pretty cool, if it's not already cool in your opinion. Just as we can pull blood off, we can push blood in. So we can actually do fetal blood transfusions using this technique. Wow. That's pretty cool in my opinion.
So would this always be done in like those women who already, it's known that they have the antibodies?
Absolutely. Yeah. Not always. I suppose what we're doing, we're going to do the least invasive first. So we're going to be doing ultrasounds and non-stress tests and that sort of thing. And if everything looks good, if baby's telling us he or she's doing okay, we're going to assume that they're not severely anemic. But if they're giving us signs with the ultrasound or the fetal heart rate interpretation that they're struggling, then we would do something like this. Yes. Early in the pregnancy, we might do what we call a chorionic villi sampling, and that is literally taking a piece of the chorionic villi, which is, chorionic villi is a developing placenta. So this is a diagnostic test for chromosomal abnormalities. So they might have screened high risk for a chromosome, Turner syndrome, Down syndrome, that sort of thing. But they want to know the answer. And depending on where they are in the pregnancy, this might be the way to get the answer. All right, certainly not without its risks. It's very invasive. It's done about the 10th or 12th week, so a little bit earlier than we would be able to do an amniocentesis. All right, and it's going to give you the definite of whether there is a chromosomal abnormality. Pretty impressive. Again, ultrasound guided in through the abdomen, in through the abdomen, low abdomen, or depending on where the placenta is that they see on ultrasound, they might actually go up through the cervix to get this little biopsy. It's like a biopsy. Then we have some blood tests. The blood tests are those screening tests that I spoke of a moment ago. It is simply a screening test. The quad marker, and I think we talked about first trimester screening, the nuchal, did we talk about that last week, right? So we have some tests like that are screening for chromosomal abnormalities. The quad marker is later in second trimester. We're testing 4 different things in mom's blood. It's just a blood test on mom's end. And depending on what those results are, will give us a high or low risk for Down syndrome or open neural tube defects. All right. Alpha fetoprotein happens to be one of those things they're testing in the quad screen. We can test AFP or alpha fetoprotein separately, just that test, and that will tell us more about open neural tube defects and Down syndrome. I remember this, I think I said this last week, down low. I don't know if I said that or not. You know the term down low. So just know that if the AFP is low, it's a Down syndrome risk. That's the only way I remember it. If it's high, it's open neural tube defect, possibly. So low means Down syndrome, down low, okay?
Does that mean guaranteed or?
No, it's just a screening test. It's simply a screening test. They might do some more screening tests and then get more invasive if they really want a definitive answer, all right? Some newer testing, we call it a sequential screen. The sequential screen is taking the information from the first trimester screen, which is that finger prick, get a blood sample and the ultrasound to check the thickness of the neck. That's the first trimester screen. A little bit later, in the early second trimester, it's a blood test for mom. And then we gather the information from both of those tests, combine it, and it's just a more specific risk. But it's still a screening test, not a definitive. Another blood test, which is within the last 10 years, probably not quite that long, is called cell-free DNA test. This blew my mind when I discovered it or was told about it. It is a blood test for mom. Some very smart person discovered that there is minute amounts of fetal DNA in mom's blood. Wow. So they figured out how to isolate the fetal DNA from the maternal DNA. Yeah. So at like the 12th week or something along those lines, they can isolate the DNA and come up with a pretty accurate risk and gender at 12 weeks along from a blood test.
Sounds expensive.
It probably still is, but it's less expensive than a amniocentesis. It's a blood test. It's the last I heard, it was still considered a screening test. And insurances covered it for high-risk people. I think eventually this, because right now it's like 99.8% accurate. That's pretty high, but it's not 100% accurate. So right now it's still considered a screening test. But I think that's pretty cool. Any questions? Not going to expect you to know the minute details of these things, but it's important just to know that there are plenty of ways that we are assessing and checking the well-being of the fetus during pregnancy. Okay?